This is Andy Orm at O'Reilly. I'm talking today with two people who are doing some interesting work on clinical trials and patient adherence to medication. One of them is Lise Worthen-Chowdhury of the Wexner Medical Center at Ohio State University. The other, who I'll be talking to in a few minutes, is Michael Gold of Farsight. So, Lise, perhaps we can start by talking about what most doctors are doing now, how they bring a patient in every 6 months and lecture the patient. You got to lose more weight. How are you doing? Are your meds okay? So, what is wrong with this model?
Well, we know that after someone has had a cardiac event, say a heart attack, a myocardial infarction, every additional rehabilitation session that they come to, it's basically an exercise session, but it's a structured exercise session. Every additional session they come to improves their lifespan. They will live longer. Every single session they come to enables them to live longer. And insurance will pay for 36 sessions, but people still don't come to these sessions. So the doctors are really interested in trying to extend the lifespan of their patients. They really, really want people to come to these exercise sessions. We're working to try to help the doctors and help the patients to get to those exercise sessions to see the long-range benefits.
So, what is the project trying to do to increase the adherence?
So we've got two approaches. One is to take a big data approach. This is being done by several people. We think we've got a kind of a special twist on it. We want to look at all the data on a person. Now that we have electronic medical records, we have a lot of data on a person. And we want to look to see, are there simple things that we could do to make it easier for them to adhere? Could we recommend that they go to a site closer to home? Could we recommend a certain time of day? Could we recommend a certain season for them to perform their cardiac rehabilitation? So in addition to that sort of big data platform, within the platform, we're building in functionality to test some interventions. Right now, to remind people to come to their sessions, you just get a call from the doctor. Usually it's a robocall and says, hey, you've got a session scheduled. It kind of feels like it's coming from the man also. So I don't think it's really working all that well. And in fact, up to 2/3 of people who start cardiac rehab, so they intended to do cardiac rehab, they drop out. That's not even including the people who just don't bother to enroll in the first place. So we're looking at whether text messages from your loved ones, your family and friends, would be more motivating than a phone call from the hospital. We just want a simple text message before somebody would have to get in the car to go to cardiac rehab saying, hey, it's your wife, please do this.
Yes, and so someone who is, say, a caretaker for an older parent could also sign up for this.
Definitely, yeah. There's been a lot of interest actually in kids being able to partake in this, especially since the kids don't always, very rarely, live close to the parent. So the parent goes through this sort of near-death experience, right? I mean, I had a heart attack. And the child really wants to be able to partake in that. And couldn't we just use text messaging, a really simple text solution, to bring the child into that and use kind of an asset that the patient already has, their social network, their family network.
How do you get the names of the people who are important to the patient? Is it from the patient, him or herself?
It's from the patient. The patient suggests the names. The patient sends a text message or an email or a phone call to that person, and then that person, the friend or family member, has to call us back and say, yep, that's good, I'll do this. And then there's documentation that we get from the patient and from everyone who agrees to partake in this study. It's called informed consent, and it's part of the standard protocol that we have with all patients when we do studies.
So how many people actually follow through, that you do get names from the patient and the family members do respond and do it?
We're currently enrolling, so it's a little bit hard to say, but so far, if the patient is interested, their family and friends are interested as well. That's what we've noticed.
So, based on this experiment, what is your vision of what doctors and patients and family members will do in the future?
On a visionary level, I just think medicine health has to be much more relevant to people's daily lives. Whether that point of contact is your phone or your iPad, with all the technology that's coming out, I think it's going to be really interesting what we end up with. But in general, we don't want the doctor's guidance or the checking in for preventative health reasons to be this thing that you do every 6 months that you have to schedule an appointment for, that often this appointment gets moved. We want you to just be able to say in the moment, hey, you know what, I just had a heart palpitation, and have that go to the doctor and have that taken care of. We want to integrate it in your daily experience. And we think right now the mobile health arena is really moving rapidly to make that happen. We've got lots of apps coming out. We haven't really done a great job of integrating with electronic medical records yet, or messaging doctors and initiating a point of contact that way. So I think that's where we need to go next.
And I suppose if there are more interventions that take place remotely, we could deal with the cost of healthcare, which is another obsession in that field.
Absolutely. Certainly we think that's going to dovetail really well.
So now I'm going to talk to Michael about some of the technical aspects of the experiment, the data, how you're going to use it to look at patterns. Do you want to tell me what kinds of data you're collecting?
Sure. There are two types of data that we're collecting. One is historical data. So we're trying to uncover what are the risk factors of non-adherence. So what are the aspects of an individual's background, health history, and daily behaviors that contribute to completing the cardiac rehabilitation program or not completing. So we'll look at things such as demographics. You're looking at gender, income, ethnicity, these types of things. We'll also be looking at their social behaviors. Are they smokers? Are they employed? Do they have children? Are they primary caretakers of those children? And we'll also look at their health history. What type of reason brought them to the hospital, and so on. And then finally, we'll be looking at their location. So what's the impact of distance from their home or work to the cardiac rehabilitation program, and how does that impact their likelihood of coming to a session? Because frankly, if you drive 5 minutes versus a half an hour, that's likely to influence how frequently you go to your cardiac rehab program.
I suppose you collect this data while they're still in the hospital before the experiment starts.
This is part of the study that we were approved to do, where we are taking anonymized patient data through the electronic medical records of folks that have enrolled in cardiac rehabilitation historically, so that we can do a longitudinal study about those drivers of adherence. So that's the one part of the data analysis. The second part of the data analysis is, once we've isolated what factors we believe contribute to adherence and non-adherence, is then enrolling the patients, as my colleague Lise mentioned, and really understanding the value of social text messaging to improve adherence from the baseline that we understand based on the historical analysis.
So you're going to do the typical trial where patients are divided into two halves and some get the messages and some don't?
In that sense, it is typical, although we hope that this new approach that we're bringing with social text messaging will give us non-typical results. We hope that we're going to be driving engagement and really socially relevant health interventions. Something that Lise mentioned is, there are all these great mobile health apps out there that large and small companies are rolling out and making available to folks today to measure your heart rate, your sleep patterns, your caloric intake. And these are very personalized, health decisions. You have this whole other class of health-related activities that happens in the hospital. Obviously, if you're in a heart attack, you're going to be in the hospital. So what we're trying to do is bridge the medically supervised health care delivery with personal health delivery in the mobile health movement. So how can you help a person who has to be in a hospital for some period of time and then is a part of medically supervised cardiac rehabilitation, but take advantage of some of these more personalized tools as a part of the mobile health movement. So that's where the social text messaging comes in, and the opportunity to really bridge the gap between what you do at home and what you do at the hospital. Because ultimately, for healthcare to deliver better outcomes at a decreased cost, it's going to be about the individual and the individual's decision. As much as we have the know-how related to cutting-edge drugs and clinical best practices, we have to encourage the individual to make the right decisions on a daily basis. And we hope that this social text messaging for cardiac rehabilitation will provide one small kernel of a direction towards making that possible.
So I suppose you'll be measuring the whether they come to the rehab sessions, but are you also measuring outcomes, readmissions, high blood pressure, that kind of thing?
In this study, the narrow focus is, did that individual come to cardiac rehabilitation? There are 36 sessions as a part of a standard of care that insurance covers, and so we will note, did that individual come to session 1, session 2, session 3, and that's really the focus of this study. Now, we know, based on research that has come out of other clinical trials, that cardiac rehabilitation is correlated with better outcomes. So we don't necessarily need to prove that in this project. What we're really focusing on is the social text messaging aspect and how that can improve adherence.
Well, there are a lot of speculations and a lot of articles about the value of social media in health, both what patients do and what the clinicians do, but it seems like this is a very rigorous approach. It's trying to see whether there actually is an effect.
Yes, we hope through our historical analysis that we'll be able to really uncover the drivers, and then working with Lise and her team of clinicians and researchers here at Ohio State University, that we'll be able to have defensible and very rigorous results, as you mentioned.
Is there anything else you'd like to say about the study?
Well, as I mentioned, with any clinical trial, you want to focus very narrowly on what you're trying to prove. And we're really trying to prove here the value of social text messaging. And we chose text messaging because the patient population of those that get heart attacks are not the Facebook generation. They're not even the MySpace or the Netscape generation. And so we hope that text messaging is a ubiquitous enough capability, and we believe it is the case, so that it can be widely available. So the value is in understanding the power of very sophisticated text, social networking such as Facebook and others, but bringing it down to a very accessible and ubiquitous medium. And so that's really the value of this approach, and what we hope is going to be a novel innovation here, since so many folks that have health issues are in the older generation.
So it seems you've chosen a very simple kind of intervention, this text messaging or phone calling, which is both appropriate to the population and something that's easy to measure.
That's our hope, and keeping it simple will hopefully give us the best outcomes, and then ultimately help it scale. If it's too complicated, then the barriers to adoption within our institution here at Ohio State University that we're working with, as well as other hospitals, would be difficult. So we hope that low barrier to entry will make it something that people are excited to try.
I really look forward to seeing some results. Thank you.
Wonderful. Thank you.